All right, here we go. Okay, so the arthrokinematics are what is happening to the head of the humerus in the glenoid as you move into, let's do abduction. So the arm, the bone is moving into abduction, but what actually happens at the joint is a roll and a glide. A roll and a glide. And we're going to talk about these motions in those terms. So rolling is like you set a tire on its treads and push it across the room, right? That's rolling. So the points on that tire are changing as it moves across the floor. It's touching on different parts of the tire. If it's gliding or sliding on the floor, that's like when you hit your brakes on an icy road, your wheel stops moving, but your tire slides along the icy surface. So it's the same point on the tire, but you're moving along different points on the surface. And spinning is when the tire, you're stuck in mud, and the tire is just spinning, and it's not moving from that point that it's in contact with the ground. Okay, so it seems very basic, but things, of course, as kinesiology does, start getting very muddied, which is what we do best in kinesiology. So we're talking about motion at the ovoid joint. So we're talking about the joint that has a convex and a concave surface. The convex surface, if the bone with the convex surface is moving on the concave surface, like on the top there, as the bone moves down, the convex surface actually glides up. If it's a concave on a convex surface, as the bone moves down, the concave surface moves down as well. So can you see that from those pictures? That makes sense? So basically, if you have a concave bone moving on a convex bone, the glide is going to be in the same direction that the bone is moving. The end of the bone is moving. Okay, we're going to look at this a bit more. And why does this matter? Why does this matter to us? This matters, once again, when we get into musculoskeletal and we have to increase motion at a joint. If the bone didn't slide that direction as it moved down, it would actually fall right off the lower lip of the bottom of the concave bone. See that? If it's just rolling down, it's just going to roll right off the bone. By gliding up, it helps keep that bone in the joint itself. On the bottom part, if the bone didn't glide in the same direction that it's moving, then it would actually kind of fall right off the other side of the concave bone. You would lose contact with the surface, the bony surface.
How do we know when it's rolling versus spinning?
Spinning only occurs in a couple of joints, so that's going to help you, right? So think about those joints that spin, the head of the radius. That's a spinning. That's the difference between what your head of your humerus does in your glenoid, right? So just to exaggerate, I've got my arm down in neutral position. I'm going to abduct my arm. If I don't glide down, I'm going to come right up and jam up into the acromion. I've got to slide down to keep it in the joint. If I yeah.
Sorry, is the top one gliding, the bottom one sliding?
They're both gliding. Gliding, sliding are both used interchangeably.
Okay. To be clear, they both have a glide and roll at the same time.
Right. Yep. Yep. I haven't talked. The roll is what's going on as the bone moves, right? So the surface of the bone is rolling like that, and it's also gliding. So gliding is translatory.
You can't have one without the other?
Correct. You can't have you can have a glide without a roll, but you can't have a roll without a glide.
I think the key thing to remember for musculoskeletal is if you're trying to increase the flexion of both those joints, on the top one, if you know your anatomy, you're going to push A upwards. If you push A upwards on B, you're doing the wrong thing. So you need to know your anatomy to be able to know which way you successfully glide to do at the joint to increase range of motion. That's why you've got to know what bone is moving and what shape it is on what other bone.
Right.
Does that make sense?
And that's where we're heading with this. So we're going to talk about this for quite a while. Don't worry, it's not just one slide. We're going to beat this one. But if I have a frozen shoulder, my shoulder no longer moves into abduction. I stop right here. If I want to improve the abduction of my shoulder, it's the top picture, I have to, in that case, glide it down. Right? I have to glide my humerus down on my glenoid. There may be a circumstance when you have to fix you wouldn't do it in the shoulder, but say you've got the radiocarpal bone, right? So convex distally, concave proximally. So if I'm going to glide my wrist on my hand, then I'm going to glide it in an opposite direction. If I'm going to glide my arm on my wrist, I need to glide it the same direction. So it depends on, you have to know your shapes of your joints to understand what direction to move to improve range of motion. All right, so just plant that seed for now. We're going to talk about that a bit more, okay? But that's the clinical relevance of all of this. Okay, so here's the roll again. Let's talk about the roll. So this is movement where equal intervals on a joint moving surface contact points on the opposite surface. So it's a tire rolling across the floor. Point A on the tire is going to contact point A on the ground. Then you're going to go to point B and point B, point C and point C, right? So you're going to be contacting different points on the ground with different points on the tire. The glide or slide is a single contact point on the moving surface as it goes along the opposing surface. So it's fixed and it's moving along a surface. This is translational and it has no rotational component, just translational. So in the picture, the head of the humerus there, if you glide or slide it, you're staying the same point on the humerus, but you're gliding along the glenoid. There's no rolling there.
Would the wrist also be an example of this? Like gliding like that?
Yes.
And going like that?
Not exactly. Not exactly. So when you think about moving your shoulder, I'm abducting my shoulder. My head of my humerus is rolling along the glenoid, right? So a point here and a point here. I go up like this. I move to another point in my glenoid, another point on my humerus, another point on my right. So I'm rolling, but there's also an element of gliding. So if I'm moving this direction and I don't glide, I jam up against structures. So you roll and glide at the same time. So that's what we're talking about. So this is the roll, this is the glide. Everybody see that? So that's how we move anatomically to keep our joints in correct alignment. And when that goes off the rails, that's when we end up with limited motion, pain, restriction. And we help with the glide as therapists to increase the motion in a joint when there's some restriction. All right, so just here's another one. This is the knee. So you've got the femur and you've got the tibia. Convex on a concave tibia. So in this case, I'm rolling into flexion, but I'm also gliding. So if you think about the tibia, the femur on the tibia, if I just roll, I'm going to roll right off the back in flexion. My femur is going to roll right off my tibia unless I glide and keep it centered in the joint. So in this case, it's a convex moving on a concave. So my bone, when I flex, my femur is moving posteriorly. So the glide is opposite. The glide is anterior. If I fix my femur, I'm hanging my leg off the table, my femur's fixed, my tibia is moving on my femur. As I move into flexion, it's still a posterior roll, but this time it's a posterior glide to keep the tibia under the femur.
Because that's a little confusing on that one, because the glide is showing the posterior glide, if you're saying that was going on at the same time, right? Your right-hand diagram shows the posterior glide.
It does. Well, that's inaccurate, isn't it?
Yeah, so, I mean, they're just showing two things, they don't occur at the same time in that thing.
Yeah, that doesn't make any sense. So in this case, the convex is moving on a concave. So the glide should have been opposite. I have used that for 6 years now, and nobody's ever caught that, Ben. No wonder everybody's so confused. Okay, so in this case, the roll is to the left. The glide should have been to the right. Good catch. That was out of a textbook, too. I'm quite certain. I didn't create that one. Okay. Anybody else catch that and get confused? You can admit it. It's all good. Okay, so spin is basically just rotation. So it's that. I mean, you can talk about. They kind of talk about the femur and the acetabular being a spin. It's not the truest spin because we are going to learn about gliding that motion when we get to musculoskeletal. So when you think about spinning, think about the head of the radius and the medial atlantoaxial joint. Atlanto-atlas, Atlanto, C1, C2. Okay. So A, rolling. What's B? What would we call that? Spinning. And C is gliding. That's basically what we're talking about. If you get those concepts, things will start making sense. Okay, and again, we already kind of talked about this. If only roll took place, the moving bone would tend to dislocate. So with the pure roll, whether it's convex or concave, you're going to lose the position in the joint if you only roll without a glide. If only glide takes place, the moving bone would tend to impinge and prevent full range of motion. So if we only glide, we also lose the positioning in the joint and cause impingement or loss of motion. So we want both. when we do the gliding in musculoskeletal, it's not usually huge translations of motion, right? It's small amounts that allow that bone to move correctly in the joint. So it's not like you're going to be, moving them 3 and 4 inches at their shoulder. And it's something that comes with practice, and we're gonna do that in musculoskeletal. So here are your rules as we talk about which way to glide things. The glide is what really matters to us. So the 2 rules are to decide which direction the shaft of the bone is traveling. So is the shaft of the bone moving anterior or posterior? Is it moving superior or inferior? Is it moving medial or lateral? So determine what direction the shaft of the bone is traveling. The roll is always in the direction of the bone movement. Then you're going to determine which joint surface is relatively fixed. So is the convex segment fixed and the concave moving? In that case, then, you've already determined the roll. The glide would be the same direction. If the concave segment is fixed and the convex segment is moving, then if the roll is superior, the glide is inferior. Right? If my concave segment is fixed, so with the femur, if my concave segment is fixed, in the knee, which segment is fixed, the tibia or the femur? The concave is fixed, so the tibia is fixed. So I'm moving the femur on the tibia. So if I'm in standing and I go to sit, which direction is my femur moving in? Anterior, posterior? My femur. What direction is my shaft of my femur moving? Posterior. It's the concave moving on, or convex moving on concave. So my glide would be anterior. Right? The shaft of the bone is moving posteriorly, so my glide has to be anteriorly. Okay. So let's do shoulder abduction. If I'm abducting my shoulder, what direction is my humerus traveling in? Let's call it superior. So what bone is relatively fixed? What's the other side of the shoulder joint? Scapula. So the scapula is fixed. The fixed bone has what type of joint surface? Concave. So what are the resulting arthrokinematics? So if this is my motion, what direction is the moving bone moving in? Superior. It is a convex on concave, so what direction is my glide? It's opposite, so it would be inferior. Yes?
What if it's like not a fixed, if one of the segments isn't fixed, like if you're doing a closed chain, say like a push-up where...
Okay. The question is if it wasn't, if neither of the bones appear to be fixed, which would it be? So in that case, when we go to doing manual therapy techniques, we are fixing one bone artificially and moving the other bone. So you will know which one is fixed and which one is moving. But if we're talking about a closed chain like a push-up, the hand is relatively fixed. So if we were talking about, let's do the radiocarpal because I think that's more obvious. If your hand is fixed on the ground and you're pushing up from a push-up, the bone that's relatively moving more is your radius ulna. So then it would be a closed chain. So it would be the concave moving in, or the convex moving on the concave moving on the convex.
What about at like the elbow? Which one would you classify as more fixed?
In that case, I would still argue that the hand distally is more fixed than the upper body, which is allowed to move. So then it would be, again, the concave moving on the convex. Yep. And in that circumstance, if you were to glide it in the clinic, you would be gliding the humerus on the ulna or radius. Everybody follow that? Makes sense? Good, because we're going to beat this one to a little bit more of a pulp. Okay, seated knee extension. We already kind of talked about this, I guess. What direction is the lower leg traveling in for seated knee extension? So I'm sitting on the edge of the table and I'm extending my knee. So the lower leg is traveling. You could call it anterior. You could also call it superior. Nomenclature, I mean, as long as you understand what you're talking about. What bone is relatively fixed? The femur. The fixed bone has what type of joint surface? Convex. So the resulting arthrokinematics, you can call it an anterior roll, anterior glide. You could, I mean, I suppose it could be superior too if you use that verbiage. All right. So just kind of wrapping it up, what does this mean to us? So joint surfaces glide when we move. They have to glide. That's that instantaneous axis of rotation that we talked about. I think in the first lecture we talked about the instantaneous axis of rotation. This is why there's not a fixed axis in our joints when we move, because that gliding forces the axis to change. We can facilitate motion in a resisted joint, but we have to know which way to move the bone. Otherwise, we're just jamming it up more or not making the person better. So we have to understand the anatomy of the joint that we're working with, and we have to understand the surfaces, the ones that we're moving and the ones that we're fixing. So the shape of the joint matters. And this applies to any joint surface. So, you know, we're going to learn all about these glides. We're going to glide the shoulder. We're going to glide the DIP joint, right? But you have everything you need right now to know how to glide any joint in the body. This is all you need. Musculoskeletal's just going to, you know, like elaborate on it and give you details. But if you know a joint surface, you know which way to glide it. All right, so immobilization. Let's leave arthrokinematics for now. We will come back and revisit those at some point. But immobilization also has a huge impact on what we do as therapists. So we see a lot of people who've had restriction from a cast or from some kind of an injury. They've had a prolonged hospitalization. So what does that mean to us? They can have limited mobility because of inflammation. You know, they've got a knee that is swollen or whatever, so they don't move it as much as they normally do. Denervation can cause immobilization. So somebody who's had a stroke and they lose some of that neural control. They have a peripheral nerve injury from a surgery and they lost their neural control. All of those things can happen. Had a patient who had an anterior hip replacement done. One of the first ones I ever saw. This was probably 10, 12, 15 years ago. And one of the scary side effects of an anterior hip replacement is that the femoral nerve runs right through the area that they're working on replacing that joint. And this person actually had damage to their femoral nerve. So, you know, lost all the function that's supplied by the femoral nerve, which is massive, right? So that kind of thing ended up causing all sorts of problems with her control of her leg. If immobilization is due to inflammation, the joint is going to want to go to the loose pack position. That open pack, loosest position of the joint is where the swelling has the most room. If you take it out of loose pack and put it closer to a closed pack position, that swelling causes extensibility in the tissue. It pushes against the joint, and that's where you get pain. So the person is going to seek the loosest position in there with an inflamed joint. So you end up with a capsule that actually becomes tight and muscles that become shorter. Ligaments and tendons also have a decrease in their collagen content and cross-linking, so they weaken. They don't have the ability to withstand the stresses that they did before. So they are less stiff. They lose 50% of their tensile strength in 8 weeks. And tensile strength is the ability to resist that pulling apart, right? So they lose half of that strength. So when you come out of a cast, let's say you had a trimalleolar fracture, which is a pretty good injury at your ankle, and you've been immobilized for 8 weeks, now we're going to start working you in weight bearing and that sort of thing. Their tensile strength is way low. So we need to gradually build that tensile strength back up because they're at a high risk for re-injury until we can get that tissue to remodel itself after we put that extra stress on there. It can take even up to a year to regain that strength. So if anybody here's had an ACL repair, an ankle sprain, or a fracture of some sort, you have experienced what that recovery period is like. And so if somebody goes back into a game too early, they frequently have re-injury if they haven't gotten to the point where their ligaments have remodeled and their muscles are stronger and their joints move like they're supposed to. So this is that stress strain curve that we talked about earlier. And this is looking at this was monkeys who were immobilized. So there was a monkey that was immobilized, poor little babies. I have a huge appreciation for people who do animal research, but I'm such a softie, I couldn't do it. So vertebral segments from monkeys is what they looked at here. So the peak that is higher is normal, and then the immobilized one is lower, that shorter curve, slope. I keep forgetting terminology. So there's a significant decrease in stiffness, and the immobilized one is more compliant to force, right? So if I'm putting force on these poor little vertebral segments, as the force increases, the normal one has much less deformation as that force is increased. The immobilized one, if I put a force on that tissue, is going to be fairly compliant and it's going to deform much quicker. And then their failure point actually is at the same length difference, but a much lower force with the immobilized. So that's why we have to remodel and add progressive loads as we work people in rehab. All right. So it takes lower loads on the tissue to cause significant deformation and increased compliance of tissues. Articular surfaces and bone is also affected by immobility, so cartilage is going to atrophy. Remember that loading, it gets its nutrition from loading and unloading. And if we're not doing that to a joint, it doesn't get the nutrition. So you get some atrophy. The protein synthesis is decreased. And it doesn't stand up to compressive loads as well, right? Because it's lost some of its proteoglycan structure. Bone loses its strength. You can have like localized osteoporosis or osteopenia. So the bone has actually been destroying more bone than it's generating. That's what osteoporosis is, and it can be localized to that area. So and that again, we know that cortical bone And cancellous bone responds to stress. So we need to gradually increase those loads, and we need to know how to do that safely so we don't cause injury, but we don't delay their healing. And that's the expertise that you're going to get over the next couple of years. So exciting, isn't it? All right. So those were our objectives. Any questions? I can't believe we ended early. Ridiculous. You want me to go back over something else? I mean, I'll talk some more about roll and glide. I can talk about that all day long. Right, Ben? No questions? All right, so let me just let you know the exam is a week from Friday. I'm going to hopefully have a review, kind of an exam review guide for you on Monday. That's my plan. So that will kind of direct you to the areas of importance, and it covers up through this lecture. So next week we'll start the new exam content. Yes?
For the anatomy quizzes, are those on Canvas?
Oh, yeah, the anatomy quizzes. The anatomy quizzes are going to be 5-question quizzes, and you will have to take them until you get all of the questions right. So, and they'll be on Canvas. There's no limited time. You just have to answer them and move on. If you get 4 out of 5 right, you have to go back and take it until you get 5 out of 5 right. It's more important to me that you understand the anatomy coming into the regional piece so that you can really understand the kinematics and the movement. I don't want you to try to be, like reminding yourself what insertion and origin of the muscle is when we're moving on to things like movement analysis, right? So hopefully this will help you to kind of review some of that important anatomy stuff. All right. Thanks so much, guys. Have a good day.